Good afternoon and welcome to the House Health Subcommittee meeting. It is Tuesday, March 28th, the year 2023. It is 1:30 p.m. Ms. Adams, if you could please call the roll.
Representatives Hicks, Jernigan, Leatherwood,
Here.
Martin, Mitchell, Sherrill, Terry, Williams, Chairman Hawk.
I am here.
You have a quorum.
Thank you. The chair detects a quorum. Thank you very much. Any personal orders from any members on the committee? Thank you. I will have a personal order myself. We've got several students in the room with us today. Some young ladies wanted to know what it was like to chair a meeting, so they got to hit the gavel, and I think they really enjoyed that. So every time I hit the gavel now, I'm going to be thinking of you ladies, and if I need to call someone out, I may bring you up to hit the gavel pretty hard. So if that happens, but ladies, thank you so much for being here, and to everyone, thank you so much for being here and for listening to us. We're going to try to get through the calendar today. If we do not, I'll make an announcement at the end of the meeting with what some potential options that Chairman Terry has left us at the end of the meeting if we happen to not get done, but let's try to get through if we can. We're going to go straight to the calendar. We are on item number 1 on our calendar, House Bill 370 by Chairman Clements. Chairman Clements, you're recognized. You have a motion? You have a second. You're recognized, sir.
Thank you, Mr. Chairman. This is a continuation of the bill that I presented last week. The chairman had requested that the administration come, I think, defend itself following my presentation. So I don't know if they're here or not. I made my argument last week. I don't want to spend any more of this committee's time. I'm happy to do so. This is obviously seeking to require state government to seek out and receive federal funding for HIV prevention, treatment, and monitoring. I'd love to hear from the administration on this if they're present and you want to go out of session.
Thank you. Any questions of the sponsor? Ready to vote? All those in favor, please signify by saying aye. Aye. Any opposed, please say no. No. The noes have it.
That's pretty pathetic.
We are now on item number 2 on our calendar, House Bill 1457 by Chairman Cochran. Chairman Cochran, you're recognized.
Thank you, Chairman.
We have a motion. We have a second. You're recognized, sir.
Thank you, Chairman and Committee. And House Bill 1457 is a bill modernizing the oversight and regulation of physician's assistants. That's a section of our code that really hasn't been updated since about 1999. This bill it sparked a lot of great conversation, I think, among all the stakeholders. I appreciate all of your time and your patience with this bill as well. We're going to continue that conversation through the summer. If you don't mind, I'm going to request that we roll this bill to the first calendar of 2024.
Thank you. The request has come from the sponsor to roll House Bill 1457 through to the first calendar of 2024. Seeing no objection, your bill is rolled.
Thank you.
Thank you, Chairman Cochran.
Thank you all very much.
We are now on, there we are. We are now on item number 3 on our calendar. We'll let Representative Hale have a moment or two to come to the podium. Ladies and gentlemen, we are on item number 3 on our calendars, House Bill 242. Representative Hale, you are recognized, sir. You have a motion? You have a motion? Second. We have a second. You're recognized, sir.
Thank you, Mr. Chairman and committee. House Bill 242 is a bill that we have worked on for several months, and I'm thankful for the work of the various stakeholders in this, along with you, Mr. Chairman, and the many conversations that we've had. And I've talked to the Senate sponsor, and we still believe that there's some work to do on this bill, and so I'd like to ask that we roll this bill to the first calendar of 2024.
Thank you. You've heard the request. Chairman Jernigan, you're recognized.
Vince Lombardi said you didn't lose, you just ran out of time.
That's right.
Okay.
That's right.
Chairman Terry, you're recognized.
I do want to make a comment on this, and I do thank you for bringing this, and I think you've sparked some conversations that have to be had. And so, giving people time, I think it's brought a lot of awareness to folks. We've had some discussions amongst ourselves. Thank you for bringing this, and hope to see what product you can get next year.
Thank you, Chairman Terry. I will make a comment as well. Representative Hale, you have done a stellar job presenting this legislation as well as working your bill with members of this committee, and there's a solution out there for this particular issue. We are headed in a good direction, and I want anyone listening to this who may be feeling some concern about the legislation that you've introduced, there's an answer to this situation, and you're on the right track. I want to work with you, work with those folks that are within the organizations who work on organ and tissue donation. There's a way to work with grieving families in a way that is both proper in terms of etiquette and in terms of timing to get this done. So I feel confident that there is a solution to this issue, and I want to give you my commitment that we'll work together on this. So any further questions or comments? Seeing none, without objection, we will roll item number 3, House Bill 242, to the first calendar of 2024. Thank you. We will now go to item number 4 on our calendars, House Bill 827 by Representative Sparks. Chairman Sparks, you are recognized, sir.
Thank you, sir.
We have a motion? We have a motion? We have a second. You're recognized, sir.
Thank you, sir. House Bill 827 basically is known as the Health Care Resource Tracking System, known as the HERTS system. The legislation is needed to help emergency departments, mental health crisis teams, and families be more efficient to identify available psychiatric hospital beds across the state, a process that currently can take several days or longer as patients wait in an emergency department to get a bed, otherwise known as ED boarding. Emergency rooms are already overburdened and generally not equipped to manage people in mental health crisis for extended periods of time. Knowing exactly where all the open psychiatric beds are in the state would be helpful to help providers link patients to the right kind of inpatient care as quickly as possible, which would prevent unnecessary emergency room boarding. This legislation calls for inpatient psychiatric bed hospitals to report once a day under this amendment the number of open staff beds that they have available to which a patient in mental health crisis could be referred to. The bill leverages the health department's existing healthcare resource tracking system, which already is used by most Tennessee psychiatric hospitals to list their bed availability. I want to quote Laura Young, Chief Nursing Officer for the Tennessee Department of Mental Health and Substance Abuse Services. She discussed in Tennessee's existing psychiatric bed tracking system is in a national report and said the following: hospital systems that use the bed registry saw a reduction, let me say it again, a reduction in their emergency department boarding. I want to read a letter from a lady in the audience here. She didn't really want to speak about the bill. She's here in support of the bill. Ms. Helen, if I may, Chairman, I want to read the letter.
Chairman Sparks, you're doing a great job. I've failed to allow the amendment that you just explained to go onto the bill. That's on me.
Yes, sir.
Before you go into reading the letter, I do want to make sure we've got drafting code 6303.
Yes, sir. Correct.
Okay. Can I get a motion? We have a motion. We have a second on your amendment code drafted 6303. All those in favor of placing this on the bill, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill is now amended, and please read the letter for us, Chairman Sparks.
Thank you. Thank you, Chairman. Thank you, Committee. My name is Helen. I'm a certified nursing assistant for 29 years, now in Coffee County, Tennessee. I have dealt with mental illness since the age of 15. I'm writing about House Bill 827 with an amendment to create a psychiatric bed registry. I was held in an emergency room during a mental health crisis. I was held in my local ED for 72 hours, at which a time I was denied my regular medications, clean clothes, or regular meals. I was denied the right to personal hygiene or visitors. I was being held until a psychiatric unit bed became available. I was number 35 on the waiting list. For me, this did nothing to help, but only escalated my crisis. My anxiety was at an all-time high. For someone in a mental health crisis, the situation's lack of compassion and care from staff have a terrible effect. People may be scared to reach out for help, which turns the crisis and only gets worse. Afterwards, I was referred to the room I was held in as the torture room. I was alone, I was cold, I was hungry, I was scared. Thank God for my therapist, whom I reached out to during my ED boarding. She stepped up as my advocate and was able to find a facility that had bed openings. I was terribly traumatized, but I'm now in recovery. Unfortunately, others may not be able to recover. Today, I'm able to tell my story and hopefully make changes to help others. Members, today, more than ever, we've got a mental health crisis. Everyone on this committee agrees. Everyone in this room will agree. We've seen the effects of it yesterday. Yesterday, we've seen the effects. We've seen the devastation. We've seen the cost and the trauma that it's going to cause for generations, even a lifetime. But I have, Chairman, I do have someone here that's willing to speak on the bill as well.
All right, thank you very much. We do have a couple of folks that are on the list. Are they available to speak or just answer questions, Chairman Sparks?
Probably both, sir.
Okay. We have Suzanne Blackwood and Elliot Pinsley.
Yeah, Miss Suzanne couldn't make it, but Mr. Pinsley is available.
Okay. At this moment, we will go out of session, and we will hear from Mr. Pinsley. If you could, sir, please make sure the light's on down there. Speak into the microphone clearly when you do, and tell us who you are you with, and what you'd like us to know. We will have 3 minutes for you to present and potential for questions afterward. Sir, you are recognized.
Yes, sir. Thank you, Chairman and Committee. My name is Elliot Pinsley. I'm a licensed clinical social worker and the CEO of the Behavioral Health Foundation, which is a nonprofit policy research center based in Nashville. I also am co-chair for the Tennessee Diversion Coalition, which has existed since 2016, working on how we can help folks with mental health and addiction issues find ways to access care and treatment without necessarily getting wrapped up into the criminal justice system. We work very closely with our law enforcement partners, providers, state departments, and all sorts of individuals involved in trying to come up with good policy ideas that can help folks move forward that we can recommend to you all here. I appreciate Representative Sparks inviting me to give testimony today. He has done a great job explaining what this bill does. This did come out of a committee of the Tennessee Diversion Coalition. We have an emergency departments committee that started about a year and a half ago after some concerns were elevated across a number of our members about experiences of individuals who are waiting for extended periods of time, days, sometimes weeks, for a psychiatric hospital bed to open up. And that led to a lot of work among the top experts in this state to figure out what can we do to help come up with some solutions. What is being done in other states to solve this? And this legislation is one of those things that we decided to recommend this year, and we appreciate Representative Sparks carrying it. This bill, in addition to what Representative Sparks said, it's also going to help identify that psych hospital bed as close to a patient as possible. And I'm not sure if folks here have heard from the Sheriff's Association, but they are in support of this legislation, and they have said that they like anything that will help them reduce the number of unnecessary trips across the state. That a lot of times they're taking folks all the way from one region on the east all the way to the west, sometimes to other states, because that's the closest available psychiatric bed that's been available. But if we have a system where every psych hospital in the state of Tennessee is regularly updating the number of available beds to which they could take a patient, then that will enable us to find a bed close to a patient that can help them get care. It can help their families participate in that care more often if they would like them to do so, and really be best practice for everyone. And this is supported by by SAMHSA. In fact, they funded a grant that the State Department of Mental Health received and worked collaboratively with the Department of Health on. And their goal was to improve reliability of data in this existing psychiatric bed tracking system we have. And I'm happy to answer any questions.
Thank you. Any questions or comments for Mr. Pensley? Thank you, sir, very much.
Thank you, committee.
We also have on our list to speak, as we are out of session, Mr. Zach Blair. Zach is with the Tennessee Hospital Association. Mr. Blair, if you could please come up before us and tell us who you are, who you're with, and we'll start the 3 minutes as you begin, sir. You're recognized.
Thank you, Mr. Chairman and committee. I want to thank the sponsor. We've been able to have several conversations about this the last few weeks, and I appreciate him and all the work that he's put into this. We have had some members that are most impacted by this legislation reach out and express some significant concerns to us that we've now brought to many members of the committee as well. First and foremost, because this is an unfunded reporting mandate for our facilities, there's concern about the resources and the staffing that will be required in order to comply and make sure that the data is being entered into the system appropriately in a timely manner. As you know, our hospitals are struggling significantly right now, so any additional burdens in that realm makes it very difficult for us to continue to focus on patient care. Also want to say that we completely agree with the sponsor, Representative Sparks, and in my previous experience working in this field, the emergency department is not the place for these patients. They're in crisis and they need treatment quickly. The issue with systems similar to this is it simply only gives a snapshot in time of bed availability throughout the state. It doesn't take into consideration the payer source. It doesn't take into consideration the most appropriate place of care. So if a specific psychiatric hospital deals with a specific issue, it doesn't take that into an account. And we have partnered with the Department of Mental Health and the Department of Health using this HERTS data to get information out and still want to support the efforts of the Department of Mental Health and their bed matching system that would allow real-time information such as payer, specialties, things of that nature that would lead to actually getting individuals outside of the emergency department and into the treatment that they require. So those are some of the concerns that we've identified. We have members that operate in multiple states, and they've had issues with these types of systems, whether that be moving past just because availability shows better in a facility. It may get them further away from home, which could be potentially detrimental to their treatment without contact with family and other loved ones, and also potentially leads to rehospitalization due to folks not being placed in an appropriate bed just because of the capacity issue. So wanted to share that with the committee. I appreciate your time and happy to answer any questions, Mr. Chairman.
Thank you. Mr. Blair, I'm going to begin. Absent the mandated reporting that we're talking about, what are our psychiatric hospitals doing now to inform the public, inform other facilities that of bed space? What's being done right now?
So, Chairman, my knowledge of the process when a patient, and typically these are in situations where there is a crisis, they may be there involuntarily and need to be moved to a facility that specializes in psychiatric inpatient care. Once that patient is identified, the provider of services at the emergency department or other facility understands what that person is dealing with, creates a first certificate of need in most circumstances, and then searches for the appropriate treatment for that individual. And again, I think that's the important part is obviously who their payer source is critical, because we have, of course, the state hospitals and 3 East Tennessee hospitals that are contracted to provide care to indigent and uninsured, and then there are a variety of psychiatric hospitals throughout the state that cover our commercial payers and private pay and other scenarios like that. So it is really incumbent at this point on the provider finding an appropriate placement for that individual when they come into that facility, and unfortunately they cannot be moved until an appropriate bed and facility is available for them.
Thank you very much. Chairman Jernigan, you're recognized, sir. Chairman Jernigan.
Yeah, and that was a question that I was going to ask as well. So when they're looking for that, is there a tracking system now?
So my understanding, there are two systems that do similar things that do it in a very different way. So the health care resource tracking system that this bill addresses, there is a portal within that system that shows percentage of availability versus number of beds currently. The Department of Mental Health and Substance Abuse Services, in addition, this is my understanding as well, they have created and implemented a bed matching system that allows providers who have psychiatric patients to access what availability for that specific patient, for that payer source, and tries to match them with a bed that's appropriate. That is the concern, is there may be some duplicative nature in that reporting, and we want to make sure that we're focusing resources on the things that will move the needle the most.
Well, if there's duplicativeness, then why would you need more manpower? You said that you needed to add more resource to do this, but if it's those two don't equate.
Yes, sir, that's correct. I mean, there are some hospitals that are already voluntarily reporting to both systems in many cases, and there are some that do not because they simply don't believe they have the resources or ability to do that as they stand right now.
This kind of brings me back to the bill we passed a couple weeks ago on certificate of need, and the psychiatrist, the one person who sends it out there, and he's searching for a bed. It seems like this system would kind of guide somewhere where, at least help where to go. I know in real time, there could be a discharge or non-discharge, and there's staffing issues and stuff. But if a bed pops up, it's worth following the lead, I guess. But that's all the questions I have for him. Thank you.
Chairman. Chairman Terry, you're recognized.
Thank you, and appreciate you coming and talking to us. A couple questions. The HERTZ system that that this is referencing to, if implemented correctly, do you see that it can be value to the hospitals and to the psych hospitals to get these patients in more quickly if it's implemented correctly?
I do believe that a bed matching system that provided real-time information that was specific to the patient and their needs would absolutely accomplish that in the future, yes, sir, as we continue to move through that process. I'm concerned that a snapshot in time of just percentage of availability, not demonstrating what that availability is for what type of patient, could lead to potential delays as people go down the list and just seek based on availability rather than the specific needs of that patient.
Okay. So, and I don't disagree if you're just reporting one time a day, and I don't know how many of these hospitals that we have in the state, but say as a physician, if you're a psychiatrist, whatever, and you're making the phone calls and you're at number 2 and they don't have a bed, by the time you get to number 20, you've exhausted everything, and number 2 may be available now. Sure. You don't know that. But my understanding is that part of the value and what the sponsor's looking at is to get people used to the system and back into the system. So just doing once a day may get those. Do you not see that could be some value of just, I know it's not real time, but just getting the members used to that system?
Sure, I don't disagree. I think the concern would be if they're looking in two different systems and we're not directing them to the correct portal to specifically the bed matching system that the department is working on, that we may create confusion on what is the best route to match that patient with an appropriate bed. So you're looking at one piece of data and then potentially looking at real-time data that actually takes into consideration payer source need, things like that, that if you tell folks, look here, or maybe look here instead of looking here, that could potentially create some confusion in the process as people are seeking referrals.
And then appreciate that answer. And one question, and this really comes to us as a body on this, and obviously this is mental health issues and finding beds and, having these patients in ERs for prolonged periods of time, that's unsustainable. That's not the answer. And I've vacillated on this bill. I'm not at this point, still not sure what I'm going to do on this bill. But if it is a priority, and it should be, let me ask you this, because some of these systems, maybe it's not, you talk about unfunded mandate and the hospital putting, you're going to have somebody that takes time and you're paying them to do this. Maybe the state ought to have, whether it's the Department of Health or somebody, we have a switchboard, and they're the ones that make the calls, and they're the ones that updates the system and try to match beds. And I mean, if it's that much of a priority to us, and it should be, with the mental health crisis that we have, maybe that's something we need to look at. I know. Obviously, this is the bill that's before us, but. And it would put a fiscal note on this bill if this bill got through, but maybe that's something we need to think about is, having somebody in the Department of Health or as work the switchboard. So anyway, that's my comment.
Thank you, Chairman. Chairman Jernigan, did you have some follow-up? Okay. Further questions while we're out of session? I think I can ask this question of the bill sponsor, so I'm going to go back in session. And without an objection, we're back in session.
Thank you, Chairman.
Thank you, Mr. Blair. Representative Sparks, as we're out of session, we heard a concept about matching a patient with the needed services there. And I'm wanting to understand if your legislation is notification, but does it help us match this individual patient with the specific services that they are needing? Can you go into that? Is that?
Well, I'd say this, that it may not be that specific, but I think the issue, the cornerstone, is mental health, and it's mental health bed that we're needing. I think that conduit now is critical. We all know it's critical more than ever. I don't know the specifics. If you want to go out of session and have Mr. Pensley to come back up and mention that or address it, that's fine with me.
Committee, your thoughts on, are we ready to move forward? Do we need to hear from anyone else, ladies and gentlemen? Okay. All right. I think we're good to go.
Okay.
Representative Sparks.
Well, I was just going to say, I've shared, I think, with Dr. Terry and some others. I went through the Sheriff's Academy back in the summer, in the fall, for the second time over the past 15 years. And the number one issue the sheriff talked about was mental health. Number one issue. He said, we're not equipped for this. They're supportive of this group. The other Sheriff Association is supportive, Tennessee Diversion Coalition is supportive, National Alliance on Mental Health, Mental Illness supportive, Tennessee College of Emergency Physicians are supportive. States that have passed this are Alabama, Alaska, Connecticut, Florida, Georgia, Idaho, Indiana, Iowa, Kansas, Maryland, Massachusetts, Minnesota, Mississippi, Missouri, Nevada, New Jersey, New York, North Carolina, Ohio, Oklahoma, Rhode Island, Utah, Vermont, Virginia, West Virginia, and Wisconsin, and hopefully Tennessee, Chairman. But I want to remind the committee that the amended version, which is this current version, has passed the Senate Commerce and Labor 9-0. 9-0. We worked with good faith with THA. We offered that amendment instead of 2 times daily. It was 1 time daily. And I'll end with this. Secretary of State Trey Hargett and I toured a local hospital. It's not Dr. Terry's hospital, but I won't say which hospital. And the CEO told me, he said, we added 16 beds. All of them are full. This guy was reaching out for help. So it's some strange irony that they're against this bill, yet when I met with the hospital, I seen the need. He had a patient on the top floor that, I won't go into detail what happened. It was a mental health situation, and something pretty severe happened. I think something pretty severe happened yesterday. I think it's mental health, and I'd appreciate y'all's support on passing this legislation.
Thank you. Are you ready to vote? All those in favor of passage of House Bill 827, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill moves forward to full
Chairman.
health
Thank you,
committee.
Committee.
All right. We are now on item number 5 on our calendars, House Bill 271 by Chairman Hicks. We have waited weeks and weeks and weeks to get to your bill, Chairman Hicks. That's one of the pitfalls of being on the committee is that you get rolled. Chair does not detect that. Do we have a motion? We have a motion. We have a second. Chairman Hicks, you are recognized. I believe we have some amendatory language as well, sir.
We do. Thank you, Mr. Chairman. The amendment that makes the bill is 6330.
All right. Ladies and gentlemen, you will notice we have a motion and a second on Amendment 6330. It's in your packet. All those, let's go ahead and get the amendment on the bill, and we'll discuss it as amended. All those in favor of placing drafting code 6330 amendment on the bill, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill is amended. Ready for explanation, sir.
Thank you, Mr. Chairman. This bill creates a new certification for psychological testing technicians to be housed under the Board of Examiners in Psychology. To my colleague from Upper Cumberland and friend, it does not create a new board or a committee of an existing board. Technicians will be certified to administer and score standardized psychological and neuropsychological tests and to observe and describe a client's test behaviors and responses. They must have a bachelor's or master's degree in psychology with a minimum of 72 hours of total education and training related to psychological and neuropsychological test administration and scoring. Technicians are not allowed to select the test to be administered, interpret the test, write the test, or give the test feedback to the clients. Technicians must be supervised by a psychologist or senior psychological examiner. The use of testing technicians is well accepted professional model that will allow psychologists to see more patients in a timely manner. Tennessee currently has a master's level certified psychological assistant that do this work, but the master's degree is required, and there is a serious shortage of psych assistants, about 65. 30 states have such certifications in some form: Alabama, Arkansas, Georgia, Kentucky, Louisiana, North Carolina, Oklahoma, and West Virginia. All have a bachelor's level testing technician in some form. There are about 150 neuropsychologists in Tennessee who will utilize testing technicians, and almost 1,500 psychologists licensed by the health-related boards, so we believe there will be a robust market for these services. That is the bill. It just makes things simpler. There's a shortage, and I believe it'll really put the psychologists out in the field where they need to be instead of trying to do tests.
Thank you, Chairman Hicks.
Thank you.
Appreciate your presentation. Any questions or comments? Questions been called. All those in favor of sending House Bill 271 to full health committee, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. House Bill 271 moves forward to full health committee.
Thank you, Chairman. Thank you, committee.
Thank you. We're now on item number 6 on our calendars. Item number 6 is House Bill 647 by Chairman Baum. Chairman Baum, you are recognized, sir. Do we have a motion? We have a motion. We have a second.
Thank you, Chairman Hawk, and I think we have an amendment.
We have a plethora of amendments, and we get to flip a coin and pick from which one we want. We've got 6, so we could roll a dice. Actually, as a matter of fact, we've got 6 amendments. So thank you very much. I understand that a committee member has brought forth an amendment that may bring together all the ideas of prior amendments and give us some language that we were also looking for as well. Chairman Baum, is that your understanding? Go ahead, sir. You're recognized,
Yes.
Chairman Baum.
Yes, I view that as a friendly amendment. I'm going to call it the Leatherwood Amendment, and it's 6726, and that's the one we'd like to go with.
Okay. All right. We have we do have an amendment by one of our committee members. Chairman Leatherwood, you are recognized on Amendment Tracking Code 6726.
Second.
We have a motion, we have a second.
All right. And you're doing pretty well there until you tacked my name onto this. And I could hear all the sighs up here at that point. So we will have to try and recover now. But what I did hear from talking to several people and constituents and others that have been hit hard with this issue, took the amendment that was passed in the Senate, which was one of the ones that the sponsor had submitted as well. So it's that exact same language, and then just added one section to the end of that. And the section that we added just clarifies the procedures and charges for Social Security disability cases, which could be, it is handled differently than other cases right now. With the Social Security, if an individual is getting these records and the Social Security Administration itself, when it's getting medical records, those rates are set. However, if an individual, when they're appealing a denial of disability benefits, if they've hired an attorney, there's a whole different set of charges and rules. So this would just add that uniformity. This portion of the amendment just provides that all parties in Social Security disability cases pay the equivalent amount, which is established by the Social Security Administration. So that's what the section we tacked on to for, again, those individuals trying to get their disability benefits from Social Security. It just helps protect them from what in some cases are pretty outrageous electronic copy charges. And with that, I will turn it back to the sponsor to explain the other parts of the amendment, which again are exactly the same as what you had prior and what the Senate passed. Of course, if anybody has questions on this, I'm available to answer those as well.
Thank you, Chairman Leatherwood. I think we'll, at the moment, we'll take action on the amendment. I believe that feel comfortable placing the amendment on the bill, and then we'll have the sponsor give us his interpretation of the legislation as well. All those in favor of placing House Amendment Drafting Code 6726 on the bill, please signify by saying aye. Aye. Any opposed, please say no. We have one no. If you wish to be recorded as no, please let the clerk know. The amendment goes on to the bill. Chairman Baum, you are now recognized on House Bill 647.
Thank you, Chairman Hawk. The motivation for this bill is we have some patients who are being charged thousands of dollars for their medical records. In Tennessee code, it is permissible for patients to be charged for their medical records $20 for the first 5 pages and 50 cents per page thereafter. So just as an example, if someone had 12,000 pages of medical records, they would be charged about $6,000, and we have evidence of this in more than one example. But that in the code is for, it was at a time when all medical records were paper, and so this bill attempts to update the code for technology. Many medical records now are electronic. They're provided electronically as PDFs that are emailed to patients or their attorneys. And so this bill would cap the cost, but only for those electronic records. It doesn't touch the cost for paper records. It caps the cost for electronic records at a total cost of $80. Let me mention a couple of things. This does not pertain to hospitals or hospital records. It doesn't change paper copies, and it doesn't affect parts of the statute that deal with workers' compensation. This is an attempt this is an attempt to make costs for patients reasonable when they need access and copies of their medical records.
Thank you, Chairman Baum. Any questions of the sponsor? Chairman Williams, and I will say we do have some folks who would eventually like to speak on this legislation. Chairman Williams, you're recognized. Without objection, I think that may be helpful.
They may make my questions more intelligent.
You always ask intelligent questions, Chairman Williams. We do have some folks who would like to speak on the legislation. I believe we have Kenny Bird with the Tennessee Trial Lawyers Association and Chris George with the Tennessee Bar Association. If you could come to the table in front of us. Without objection, we will go we'll go out of session. And gentlemen, if you could please introduce yourself. Who would like to go first? If you could introduce yourself, tell us who you're with and what you'd like us to know. You'll have 3 minutes, and then the other gentleman will have as well. So you're recognized, sir.
Thank you, Mr. Chairman. My name is work at a law firm called Leaf Cabraser. I've practiced in Tennessee my entire career as a lawyer. I've been on both sides of the V, on the plaintiff side and the defense side. I've seen it all. And what we're here about today really is people trying to just get their own medical records at a reasonable price with new electronic records ability. So for example, I'll give you an example. I've done a lot of cases around here in Tennessee, represented Rutherford County. I saw former Senator Ketron back there and caught up with him in the opioids cases. A lot of counties here in Tennessee, I've done those. So that may or may not include medical records sometimes, but right now I'm representing some military folks, a lot in Fort Campbell, for these, I don't know if you've heard about these earplug cases, these 3M earplug cases that were unfortunately defective, and a lot of our men and women in the military suffered hearing loss from that. So most of those folks see the VA, and there's a system to get their records under that's very simple and affordable. But when they go see a private provider, for example, in Fort Campbell, if they go to a doctor in Kentucky, they can get their electronic records for free because that's what the legislature has done for PsyOx and all these other companies. I mean, if they go to a doctor in Clarksville in Tennessee, they can be charged, as Representative Baum says, through the roof for no reason, just simply, because they're in Tennessee. And so we don't think that that's right, just to get your own medical records. I mean, from their perspective, if you have a family member is injured or whatever, for whatever reason you need to get their medical records, from their perspective, they never contracted with PsyOx or whoever is going to speak in opposition. They don't know who PsyOx is, They don't know that, PsyOx is a big company. Senator Bailey talked about last time, I think they had a huge $7 billion merger. They make plenty of money selling your medical information to places. This stuff is not a big deal to them. And so the military folks or whoever's going to see the doctor, they haven't contracted with PsyOx. They just want to go to their doctor. They just want to get their own records. And then they're told that we're going to sell you your own records back to you for an exorbitant amount. We tried to cut, we were told to, work. We've worked with the Tennessee Bar Association, who's right here. We've worked with the Medical Association. We worked all together to try to get to a reasonable amount. And at some point, PsyOx, after being told to sit down and work out a deal, just said no. So I think that's where, we went from 25, we're trying to be very reasonable, went up to 50, and now we've got the bill that puts it at $80, which I think is very reasonable, considering Kentucky would be $0 if you see a doctor there. And so I'm happy to answer any questions, and I'm turned it over to my colleague here from the Tennessee Bar Association.
Thank you. And we have Chris George, Mr. George with the Tennessee Bar Association. Once again, make sure your light is on down there. Tell us who you are, who you're with, and what you'd like us to know. You're recognized, sir.
Thank you, Mr. Chairman and committee members. My name is Chris George. I'm an attorney in Gallatin. I'm a solo practitioner. Before that, in practice with my father. Our firm has represented Social Security disability claimants for over 35 years continuously. That's what we specialize in, and that's what we do. Before I discuss the legislation, you may or may not be aware of the Social Security disability process. It is a terribly lengthy process for an individual who becomes sick, ill, or injured to pursue disability benefits. They file an application. They get turned down. That may take 6, 8, 10 months. They're not working. They don't have any income. They're denied at about 70% rate. They appeal. And generally, that's a rubber stamp, another 8 to 10 months of waiting, no income coming in. Ultimately, a case goes to an administrative hearing, and ideally, the case is won there. If not, it proceeds on a further appellate path, which is beyond the scope of today's hearing. But again, the premise of this bill and the amendment is that when people want copies of their medical records, it's not because they're healthy. It's because something's going wrong in their life. They're hurt, they're injured, they're pursuing some sort of benefits to help their family. Concerning Social Security disability cases, as Representative Leatherwood noted, the agency, when they request records, get the records, one set of records from any source at a federally agreed upon rate. $20 currently is the rate. If somebody exercises their right to get a representative, an attorney to help them in their case, attorneys are not afforded that. Records can be very, very, very large in an age of information technology and electronic records. One treatment note for a cold can be 10 or 11 pages. So an individual is having to pay for 10 or 11 pages simply because they went to their doctor for a cold. All that we are seeking to do concerning the Social Security matter is carve out an exception where Social Security claimants, whether by their representative or themselves, are paying the same rate that the government pays to get the same records, no more, no less. This body in 2019 carved out an exception in TCA 6811-304 to where Social Security claimants who are indigent, upon furnishing that evidence to hospitals, can get their hospital records for free. People that are injured pursuing personal injury matters, workers' compensation cases, whatever it may be, are at the lowest points of their lives. And I can assure you, for representing claimants for over 17 years, when they come to see me, they don't want to be there. This is the worst position them and their family has ever been in. Let's not gouge them for more money just to get their medical records to support their claim to help their family.
Thank you, Mr. George, very much. Any questions or comments for the presenters? Chairman Williams, you're recognized.
Thank you. Is this for third-party billing or is this individual? So, for instance, if my grandmother, who had 3 hip replacements, decided she wanted a copy of her medical records, is that free if she asks for it, or is it only for third parties?
Are you asking me concerning the Social Security component of it?
No, I'm asking you as it relates to the tenets of the bill in which you came here to testify.
When you request medical records, you pay whatever the current law allows you to pay.
Yeah, it was my understanding that if you're an individual and you request your own medical records, that they can't charge you more than $6.50. But am I missing that?
I can tell you when my clients bring me medical records, they bring very large bills from copy companies, and they bring them to me in their own hand that they got them themselves. So no, I have seen that is not the case, sir.
A copy company or a medical records company?
But I don't see the distinction. A copy company, medical
Well,
records
there's a difference
company.
between getting something from a medical records company, a bill, than getting something from Kinko's.
No, these are a PSYOPs, company like
Oh,
company
okay,
like PSYOPs,
okay.
yes.
That-
I interpreted that to be the same term.
Yeah, I get you. I
Sure.
was like, wow,
Yeah.
I didn't know that was the same.
Sure.
Yeah, the chairman.
You're recognized.
Okay, thank you. And so I guess the question also, you're in regards to Social Security claims, but this bill only applies to clinics, is that correct? Or does this apply also to hospitals and workers' compensation claims? And why not those, I guess, is the question.
Well, I think it's a good question, something to talk about down the road. But right now, as the arrangement we were trying to create was just to the providers right now. And that's not something, we haven't pulled in the hospitals yet. The $6.50, just to help you out, I think, is a federal guideline. And that's a great example of, what they set. $6.50 is what they expect something like this to cost. Because they say if you want to just charge a flat fee, you can do $6.50. But there's no private right of action to enforce that rule. And so in each state, PSYOPs gets to charge, yes, the individual, all the way up to the highest amount. So we've had an example where, the $6,000 bill we talked about for a University of Tennessee student, and once PSYOPs, or I don't know if it's PSYOPs or HealthPort in that instance, but once whatever third-party record company it was, got sued for that, all of a sudden it came down to $13.50. It really doesn't cost them a lot to do this. Yeah, they let individuals sign up to their portal for free, but it's not free to actually get the records. So, admittedly so, it's my understanding that
that this bill, as amended, would set a standard as it related to electronic medical records only in clinics? Or would this amendment?
When you say clinics, I mean doctors, healthcare providers that are not hospitals.
That are not hospitals. And so what I'm saying is you have hospitals, clinics, workers' compensation claims. Those are the three medical record groups that are out there. What we're saying is this bill only remedies one of those three, and of those only medical records, or does this new amendment that I honestly have not seen today, does it also deal with paper records?
No, it only deals with electronic records and for providers, not hospitals. Okay. And we're just going to, take this one step at a time. We think it's very reasonable.
And the reason for not doing all three silos, if you will, is just convenience, or you just like to come back here year after year?
I don't know. I'd have to poll each one of you on that, but I think it's just taking baby steps, Representative.
Okay, thank you.
Lawyers love the Health Committee, so I'm sure that's why. Further questions? Okay, all right. Thank you very much, gentlemen. Hang around in case something else comes back up, but thank you very much. We are still out of session, and we have Ms. Rita Bowen. Ms. Rita Bowen is also on the list to speak on this legislation on House Bill 647. I think we continue to be out of session, and Ms. Bowen, if you can make sure the light's on down there below you, speak into the microphone. Once again, please tell us who you are, who you're with, and what you would like us to know. You're recognized, ma'am.
Thank you, Chair. I am Rita Bowen, and I am the legislative chair for the AHIOS group, which is the American Association for Health Information Outsourced Services. I am not PsyOx, so you just heard, because PsyOx is not part of our organization. However, we do work closely with them on legislative issues such as this. You raised a good question, Representative Williams, when you said, do you just want to keep coming back year after year? And that's our point. This should not be taken in silos or baby steps. The debate of pricing should be considered carefully and evaluated by all parties involved. And we are willing to negotiate that pricing with the trial attorneys, but we would recommend this go to summer session so that we can do so. Most of the records, and let me just explain, I have been in medical records and health information for 47 years. I should be retired. I have not retired yet. But I was at Baptist Hospital here in Nashville. I was Erlanger for 15 years, so I've been at some of the larger centers. Clinic records, practice records that are associated with a hospital are intertwined. You do not want to have split billing. That will not serve well in the industry. It will confuse people. We should look at electronic fees collectively. I have personally worked in the release of information industry for the last 12 years as a privacy official, and have helped to negotiate these fee schedules in 12 of the 16 states where it is regulated. And I urge you to regulate it in totality instead of a silo. Before I describe the ROI process, it is not as simple as pushing an easy button. Many people think, oh, it's an electronic record, so you can just go and push a button, it's going to just come out. It doesn't work that way, because many of the records within a facility and or even in clinics are coming from different source systems. So you have to go to those various systems to pull the document that would be used for a court decision or for a reason of validation for medical necessity or other insurance such as Medicare or for a disability. So we have a 45-step process that we utilize, so it is not a simple process. We often, in our industry, have to validate the patient's identity within a facility's own system because they will have duplicates. So someone can come in as David Hawk Jr., and then the next time it just be Junior Hawk. So I'm just going to use your names as I see them up here. So there is not an easy step, and you need to be aware of that. So when we also look at the records, we're looking at accuracy of that record too. The usability of the information within that is something that we have to also take into account, because a lot of the validation has not occurred in the process. So especially in clinic records often are just, there may be information that's out there that hasn't been approved by the clinician yet to actually go out for receipt in the process.
Thank you, ma'am. I appreciate it. We've reached our 3 minutes
Okay.
there. Thank you so much.
Other
Any questions, comments? We have Chairman Jernigan. You are recognized, sir.
Thank you. So you admitted
old.
You've been a long time, so I'm not going.
You aren't offending me.
Be
I'm
patient,
just proud
but,
I'm still ticking.
So you were around when it was just paper.
I have been.
And you saw the transition between paper to electronics.
Correct.
I guess would be, is there a big difference between the two, and do they cost the same?
It's a big difference between the two, because when you see a record produced now that's an electronic record, you see more paper than you did when it was a paper record. If you actually produce it to paper or produce it to a PDF, which is just converting it so you can receive it electronically. But there's more information there because there's data about the data. It's a computer system, so they're telling you about the data. The old record may have been 35 pages. An electronic record may be 75 pages. So the process of validating that is often, if people would ask for exactly what they're looking for, but an attorney often will say, I need any and all. If you ask for any and all, you're going to get all of that metadata, you're going to get all of that information that probably you won't find useful. But it's how it's asked for. But
Okay.
there is a difference.
Okay. Then if like, okay.
He's thinking.
Come back to me. I've got a question. I'm just trying to formulate it. And I don't wanna
We will
waste
come back
committee's
to you.
time.
Chairman Terry, you're recognized.
Thank you, Chairman. And just, and you do it's for outsourcing medical records?
I
Is that
work for
the-
a company called MRO. So yes, we do. Facilities will ask us to take on the release of information function on their behalf.
So, thanks. I guess my question is, what percentage of, because this isn't dealing with hospitals, this is dealing with either medical clinics or doctors' offices, what percentage have something in-house where they store their information in-house versus those that outsource their medical records to a third party like?
It's usually from facility-wise, but if it's a full-blown clinics and hospitals, it's 80% are outsourced. That's the tradition. If it's a one-off physician office, usually more than 50% of those are outsourced, because it's got to be a dedicated person that can actually assess the rules and the guidelines. And that is what we're finding, is that many facilities just do not have the staff to dedicate to this. So they want to outsource it so that there's someone who can do that on their behalf and do it correctly.
So and this is a third party, like an attorney or somebody getting the information, and like you said, understanding what that information is versus what needs to go out, what they can send out, what's actually being asked for. So if they're doing it in-house, and it's not something that they're used to doing, it possibly could take them a lot more man hours to be able to do that than just and take them away from whatever patient service tasks that they have at that point in time versus something that's outsourced, that if they're more used to getting that at an outsource. Would that be correct?
I would agree with that statement. Having the dedicated staff that is doing nothing but release of information in a physician office. I've only worked in one physician office, and that was many, many years ago. But I can tell you, I was pulled from here to there. I was assisting like the front desk and doing this, and you didn't have time to just do one thing. Same thing in a hospital. I mean, the hospitals are outsourcing release of information 80% of the time because they have to keep their staff to patient ratio in line. And so they're going to keep the staff that's going to be touching patients, that's caring for patients, and they'll outsource the administrative task of release of information. And if you look at some of the research for patients who have actually filed complaints regarding not getting their information, it was in facilities that are trying to do this themselves, not in a facility that had it outsourced. We are able to actually turn information around to a patient within 3 to 5 days, very quickly, if the information's not available on the portal directly electronically for them.
All right, I'm good, thanks.
Chairman Williams, then we'll go back to the other individual after that.
Okay. Just from your perspective, if Ryan Williams calls and asks for or let's say my mother calls and asks for her medical records as it relates to a total knee replacement that she had last fall and then a total knee replacement that she had 5 years ago, and she went to a clinic to see that, but the surgery was done at the hospital. If my mom calls and asks for that record, A, does she pay $0 to $6.50 if she asks for it?
Correct.
And if a third party or an attorney's group like the ones at or Terry and PLLC, if he asks for it as a third party, this bill would cap that electronic record only at $80, I think is the fee.
The clinic record, is my understanding, is what this bill was looking at. But
Okay.
I'm highly encouraging you to look at it in totality because clinic records and hospital records are often together.
Okay. And so I don't think I have another question. Maybe somebody else has one. I was trying to make sure I understood and for clarification purposes, this only, would the record that I talked about with my mom, if this bill were to apply, the records that she requested may be incomplete because the hospital equation was not included in it, only the clinical one. Is that correct?
Well, it would depend on how she requested it. If she requested her entire record, she'd get her entire record.
Okay.
And it depends on the facility. Some facilities say give it to them at $6.50, which is the safe harbor rate, which has been established. Some say we don't want any of our patients charged. So it really depends on the facility. I would say most facilities are saying do not charge a patient directly for their records. Because of interoperability now, a patient can go to their portal and pull out the electronic information themselves. So if any of you have been to the hospital or to a physician office before you leave, they usually say, oh, we have a portal and you can sign up, and if you want to get your information, you can go to that portal and pull it yourself. That's fine for people that are electronically acceptable to that information, but like my 95-year-old mother, she's not going to pull anything because she don't know how to use a computer. So I think you just got to look at what you're looking at from that perspective. But the patients are encouraged to get their information. We do not want to block a patient at all from receiving their information. That's not in keeping for what interoperability is about and not what the whole code of ethic is. We're trying to push the information to the patient to have them take more ownership in their health care. No question?
All right. Chairman Jernigan.
Okay, I'm back.
You're back.
So I guess my question is there a price point? Because clearly, it sounds like there may be some guardrails that need to be in place because do you agree that $6,000 is abusive?
For a patient, yes. For a third party, I'm not so sure. It depends on how they pull the information. So I haven't seen this specific PsyOx example that seems to be floating around and has been discussed.
Right.
I'd have to look at it before I could give you my opinion, but I don't know the specifics there. But
I think a judge gave an opinion on that. And it went down to $13.
Oh, okay.
But, yeah.
Here it did in Tennessee?
Right. So
okay.
So the guardrail. So is there room for abuse in this current system?
There's a room. I'm going to have to say it this way. There's room for abuse in any system, but I don't think from a HEOS perspective. I can't speak for PsyOx. I can only speak for the members of a HEOS. We are We do not share our price points, but we share the focus of regulations. And so we are very accustomed to looking at state regulations, and we stay within them. Now, as I mentioned, there's 16 states that we've helped to negotiate, and 12 I personally have been involved in. Those have been very, it's been a mutual decision as to what that pricing should be. It wasn't just pushed by the trial attorneys over to us. Since this is an industry that we know very well, we feel that there should be time for debate and time for negotiation, and that hasn't happened in this situation.
Do you consider PsyOx part of your industry?
They are part of the industry, but they're not part of AHIOS. They have pulled out from that because they have a different business model than the most of us have, because they have a different venue now of what they're doing.
Well, if they're part of the industry, it looks like your industry is grossing about $17 billion a year. I'm not sure $80 is going to hurt you much, but at least in the state of Tennessee, I don't know if this bill's the perfect formula, but there needs to be some guardrails somewhere.
I don't disagree. I just think that there should be an opportunity to carefully craft this and craft it in totality and not just in a silo, not just for clinics, but for hospitals in the totality of it, so that because those records are often combined.
Well, this is my last thing. That may be so, but the bill before us today is just one.
I know.
So we can't go for that. Thank you.
Chairman Leatherwood, then we'll go to Representative Mitchell. So Chairman Leatherwood, you're recognized.
Thank you. And does your company provide records and Social Security disability appeals?
We do.
Okay. And it's my understanding you mentioned sometimes, especially attorneys, might ask for any and all medical records. It's my understanding that the Social Security Administration requires that when attorneys are representing someone? I mean, is that required by Social Security Administration to do that?
I'm not aware that it is. It may be. I'm not aware of that, so I can't speak to that. I know when we provide to Social Security directly, they have a specific subset that they're looking for, or they'll tell us it's related to this specific injury, and we provide that information. So they don't usually get the entire record. Okay. I'm assuming that the attorney's involved when there's an appeal, when Social Security has been turned down or disability's been turned down, and so they're appealing, and therefore there's more information that's being requested to justify that appeal. That would be my assumption.
Does your company lose money providing these records to the Social Security Administration when they want records? Is that
the
do y'all lose money doing that?
If that was all we were doing, we would. But because we're balanced out by the different venues of how, for like third party, fourth party billers, the fourth parties would be someone who might be a record retrieval company obtaining records for an attorney, for example. We have that all the time. We have groups that actually have contracted with an attorney to get records, and then they are getting the records for that attorney. And we call those fourth parties. And
So
we
the
bill the state
social-
rates for those, but that would not be the rates for
So the Social Security Administration has negotiated fees
Not
with your
with us.
industry that
they have
results in your industry losing money, not making any profit on providing these records to the Social Security Administration?
We have
or
a
to
there
individuals
is
who are not represented by attorney? You're saying y'all lose money every time you
I wouldn't-
copy records for these people?
Let me state it this way. They have a stated rate that we can charge. We usually upload those to their portal. They can request them electronically. We send it back electronically. So that is a process we do on behalf of the facility. The way the ROI industry has worked is that there is a balance for what we can charge to third parties and fourth parties that helps negate the losses that we would receive for those kind of services and to patients.
Okay. Again, a loss compared to what you're able to charge over here, or actually no profit. Was the question. But in regards to
Well, I'm
third
not
party, we keep
finance.
talking about third party as though they're working for themselves. They are working for individuals. And the third parties are not going to swallow these costs to say, we will overcharge third parties, but we won't overcharge an individual. Well, when you overcharge the third parties, you are also overcharging the individual. And as far as wanting to look at it in its totality as opposed to one silo here and there, of course, status quo benefits the industry that I believe is overcharging for these services. And it does just make me think of the old story about the little boy and the old man on the beach, and the little boy's throwing starfish back in the water, and thousands have been washed up on the beach, and the old man says, you're wasting your time. Look at all these starfish. You can't help any of these that need help. And little boy picks up another one, throws it in the ocean, and says, it helps out this one. We've got constituents that aren't being treated fairly now. No, we might not be able to help them all today, but with this legislation, we can help some of them that need this help. And maybe we can get some other starfish off the beach later. But just because you can't throw them all back in the ocean doesn't mean you shouldn't help some who need help. Thank you.
Thank you. Representative Mitchell, you're recognized.
Yeah, thank you. And I was going to address the same lines as Representative Leatherwood did. You know, these third parties are people representing the individual, and that settlement or recovery, you know, you're overcharging is coming out of their settlement or recovery, which many of them have been waiting probably years to get in the first place. But my question to you, does your company or any of the companies in your organization ever charge something like an electronic data archive fee or an electronic delivery fee on top of the charges you're already charging per page?
Not that I'm aware of.
Okay. And, you know, you've talked about third parties, fourth party. I'm concerned about potentially fifth parties. Do you ever sell medical records de-identified?
No, not the members of AHIOS. We do not.
Okay, but there could potentially be another large
can't
company
speak
that
to
may
that.
do that?
I don't know.
Okay.
I can't represent them.
All right, thank you.
Thank you. Any further questions or comments? I will make a comment myself. I've seen issues like this come up, and we're talking about working in silos, which is sometimes how we have to begin work on these particular issues. There has to be an impetus to negotiate, and this may be the impetus to do that. I joke often about putting two sides of an issue in the same room and me cooking them lunch and making them eat my lunch, which is going to be awful, and not getting out until they come up with a solution to the situation. And that may very well be what we have to do in this situation. Ma'am, thank you very much. No further questions or comments. Ladies and gentlemen, do we need to hear from anyone else? Anyone earlier? Okay. I think we're ready to go back into session. Chairman Baum, you are recognized again on your legislation. You're recognized, sir.
Thank you, Chairman Hawk. I've spoken with representatives from SIOX, and not one time did they tell me we would have a deal if I would expand this bill to include hospitals. I'd like to do something to help our constituents that are currently being abused with high bills. This bill only covers electronic records. The charges on paper will continue as they have been. This doesn't cover hospitals. It's just a start, and it's an attempt to help our constituents in the face of a multi-billion-dollar industry largely centered in California.
Chairman Terry, you're recognized.
Thank you. And before we vote on this, I just want to have I mean, you and I have had a short discussion, but as we've had some testimony here, obviously it's become apparent that, you know, there's 80% that get outsourced, and maybe in clinics, maybe 50% get outsourced. And so one of the concerns, and I don't have enough information on this, and I don't know that you can provide this or not, but one of the concerns that I do have is that the clinics or the physicians that have this in-house, obviously they give it to their patients, but when you have a third party that's doing that and they want to get it right and make sure that all that occurs, so that, if they're giving it to attorneys or something, they're going to be very meticulous in what they do, and that's obviously got a higher cost associated and time associated with that. So if this bill moves forward, this would be something that I'd like to have a discussion with you about, whether or not removing the $80 cap on those that do it in-house, simply because, they're not as efficient, obviously, we heard the testimony, as those that are outsourced. And I don't know what a fair number is. I don't. I've heard different numbers bandied about. 6,000 is obviously not fair. But having a clinic, tie up a clinic and their resources when they're trying to see patients may be more than $80 worth. I don't know. But would that be something that you would be open to if this bill moves forward?
I would be happy to, and let me add this. If a clinic doesn't have a third-party company like Ciox, then when the patient goes to that clinic is only responsible for that clinic's medical records. They're not responsible for covering the medical records at a dozen different medical centers across the region.
Right. Thank you. Any further questions or comments? Chairman Williams.
Thank you, Chairman. Thank you, Chairman Baum. What a fun time we've had discussing this. I just feel like I greatly respect you. I think you have done yeoman's work on this bill. I actually feel like that you've made a lot of progress as it relates to this bill today, not just with this amendment, but with also the other stuff. I will say I'm a little bit concerned because sometimes I've been like Chairman Hawk and had the opportunity to put two opposing parties in a room, and they'd rather be mad as get fixed. I don't know if that's what's going on here at all, but I do know eventually they're going to have to get back in the room and fix it as it relates to the other, for lack of a better term, silos that we just talked about, because it's really not a fix. And so, and as we've had so many questions today, it just seems like on a scale of 1 to 10, as far as a remedy, this is more like, in my opinion, a 2 or 3. And so I would like to see us get it to a point where we could get it to a 7 or 8 before we end up doing something that we'd wish we'd rather changed. We don't have the opportunity to do that today. But it's for that reason. I'm not going to be supporting this amendment and consequently the bill, but I do want to take the opportunity to say I appreciate your hard work on this. There's no question that not only is this important to you, but it's also important to you because somebody from your district brought it here. But I just feel like that there's just a lot more work yet to be done. Thank you.
Thank you. Further questions or comments? You ready to vote? All those in favor of sending House Bill 647 to full Health Committee, please signify by saying aye. Aye. Any opposed, please say no. No. The ayes have it. Your bill moves forward to full committee.
Thank you all.
Encourage you to continue to do some work on the legislation and with the full committee chair. So, bill moves forward. Ladies and gentlemen, we still are on our calendar. We are on item number 7 on our calendars, House Bill 363 by Chairman Love. Chairman Love, you are recognized, sir.
Mr. Chairman, I would like to take this bill off notice.
Okay. The request has been of the sponsor to take item number 7, House Bill 363, off notice. Without objection, off notice. We are now on item number 8 on our calendars, House Bill 737 by Chairman Love. Chairman Love, you are recognized.
This one off notice too, Mr. Chairman.
The request from the Chairman Love, the sponsor, to take House Bill 737 off notice. Without objection, House Bill 737 off notice. We are now on item number 9 on our calendars. Thank you very much for your patience, Chairman Love. You're recognized on House Bill 738, sir.
Thank you, Mr. Chairman. If I can get a motion in second.
We have a motion.
Thank you. Thank you, Mr.
We're just
Chairman.
messing with you. We're just messing with you now.
And if I could,
you have a motion and a second,
yes,
Chairman Love.
if I could exchange 2 taking off notice for 1 passage, I'd appreciate that, Mr. Chairman.
Representative Love, I think we do have an amendment, some amendatory language that you've presented to the committee. have a drafting code 6150. Is that accurate?
Yes, sir, Mr. Chairman. This bill deals with doulas.
Motion and a second on the
Motion
amendment.
second on that. Thank you. As many members may know, we have a pilot program dealing with doulas right now, and this particular piece of legislation that Senator Lamar has been working on with me for quite some time would create a committee that would allow us to really study what the effects of these doula pilot programs would look like and allow us to provide more support next year. And that, Mr. Chairman, is the conclusion of my presentation. I stand ready for questions.
All right, let's put the amendment on the bill. All those in favor of placing amendment drafting code 6150 on the bill, please signify by saying aye. Any opposed, please say no. The ayes have it. You've described the amendment to your legislation. Any questions or comments for the sponsor? Chairman Williams, you're recognized.
Thank you. Leader Love, I just had, or Chairman Love, I just have a little bit of a question here. So this is a advisory committee to advise or to take the request of another advisory committee?
No, Mr. Chairman. So we brought legislation last year to really try to create a certification for doulas.
Okay.
And in conversations with TennCare and Health Department, really realized that we needed more information. And then a pilot program was developed, and I think it's in the governor's budget this year to look at doulas and look at all that they do. This committee would be attached to the Department of Health for administrative and reporting purposes.
Okay, thank you.
Further questions or comments? You ready to vote? All those in favor of sending House Bill 738 to full Health Committee, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman and committee members.
You made a very good deal today, Chairman Love. Thank you very much.
So the next two are both first calendar 2024.
Okay. Taking action on the next couple of bills. Item number 10 on your calendar, House Bill 1143. Request of House Bill 1143 to be rolled to the first calendar of 2024. Without objection, House Bill 1143 rolled to the first calendar of 2024. Item number 11 on your calendar, House Bill 1146. The request also has been to roll this to the first calendar of 2024. Seeing no objection, House Bill 1146 will be rolled to the first calendar of 2024. Looking around the room for bill sponsors. We have the Honorable item number 15 by the Honorable Chairman Reagan. Chairman Reagan has spent a lifetime waiting in this committee over the last month. And Chairman Reagan, you're recognized on House Bill 1380. Do we have a motion? We have a motion. We have a second. Sir, you're recognized, and I think you're working on an amendment as well, sir.
Yes, the amendment code is 6518.
Yes, sir. We have a motion. We have a second on drafting amendment code 6518 to go on the bill. Let's go ahead and get it in the proper posture and we'll debate. All those in favor of putting amendment drafting code 6518 on the bill, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill is amended, and please explain, sir.
Thank you very much, sir. This mature minor clarification bill is designed, and by the way, it's called the Mature Minor Doctrine Clarification Act, and its purpose is it requires parental consent for all vaccines given to minors. Currently, there is a exception that's out there. I'll discuss in more detail in just a minute. But the impact is to give parents back the rights to make medical decisions for their children. As amended, this bill basically says that anyone under the age of 18 gets a vaccine, and other than emergency conditions, only with the consent of their parent or guardian. The mature minor doctrine that I said I would discuss was put out by a court, and the court interpretation has been abused and misused. Some cases it's even miscited. The mature minor doctrine that I'm discussing violates the 1986 Childhood Vaccine Injury Act, which does require parents to be given vaccine information statement prior to the administration. Likewise, in this Mature Minor Act, there were what they called the rule, or pardon me, doctrine, is what they were called the rule of sevens. Under age 7, they were minors were assumed to have no capability to agree to any vaccine. From 7 to 14, there was a presumption of some, and from 14 to 18, they were assumed to be able to do what they wanted to, regardless of what their parents said. The children, especially teenagers, are restricted under our code. For example, we don't allow teenagers to get driver's license until they're 16. They can't enlist until they're 17. They can't get married until they're 18. What this code does is put the legal standing back where it was, so that children belong to their families, not to the state or anyone else. And their families are the ones who are responsible for their medical care, to include vaccines. I can go into some excruciating detail, but in the interest of time, I will stand ready to answer questions.
Thank you, Chairman Reagan. Any questions or comments of the sponsor of the legislation? Chairman Jernigan, you are recognized.
Okay, so just a scenario, 17-year-old gets admitted to school, college, they require vaccines, the parents do not sign off on it. Do they have to wait until they're 18, or if that college will not admit them?
The answer to your question is the parent is the one who's responsible for that, regardless of the situation. If the minor is emancipated, the bill makes provisions for that. If the minor is formally in the military and is under the age of 18, the bill makes exception for that.
Mm-hmm.
Otherwise, it's the parent's responsibility.
So just the 17-year-old who gets accepted, it's fall, they're not going to be 18 till the spring, they won't sign off on vaccines, they can't go to school.
That's the parent's decision, sir.
Okay, thank you.
Representative Mitchell, you're recognized.
You know, over the last couple of years, we've had a lot of discussion about vaccines, and I think we've seen a whole lot of misinformation given out about vaccines. I say thank God for vaccines. They've saved millions upon millions of lives in this country. You know, when's the last person you've seen with polio or smallpox? You know, but this really concerns me because, in fact, I discussed it with two experts about this piece of legislation. They were, my experts were down here last time this bill was coming into committee. It's my 15-year-old and 17-year-old. And I'm glad that I've raised two children, because they both told me that, Dad, if you wouldn't have found a way for us to get took us to get a COVID vaccine, we would have found a way to get it. And I was proud of them telling me that, because we have too many people in this country right now that are spreading misinformation about vaccines, and that not only harms themselves and their family, but it also puts the rest of society at risk on these diseases that we've more or less eliminated in this country. And the more and more we try to limit people getting vaccines, is the more and more likelihood that we're going to know somebody with polio, or we're going to know someone who dies of smallpox. So, like I said, my two experts gave me all the information I need on this bill, and I'll have to oppose this bill because there's too many situations where parents, you know, fortunately in our society now, you know, a 14 to 17-year-old or 15-year-old at times can be more educated than their parents, and I'm glad that I've got children who can think for themselves that would go get a vaccine. That being said, thank you.
Thank you. Chairman Reagan.
Thank you, Mr. Chair. I'll point out to you that in the long history of this bill in this committee, I brought some people to testify. Among them was a Mr. Rolf Hazelhurst, who testified that he is the parent of a vaccine-injured child. Vaccine injuries occur, and the parents are the ones who should be making the decisions about the risks involved, not the child themselves. We have a designation called majority, and it's after the age of 18. That's when those people make the decisions on their own. Prior to the age of 18, it's the parent's responsibility. Children belong to their families, not the state. And so therefore I submit that the parents are the ones who are legally and morally empowered to make this decision.
Before I go to Chairman Williams, I will go back to Representative Mitchell. You recognize Representative Mitchell.
You know, I've heard many times this year where we've taken the parental decision on health care, education, many things away from parents in this General Assembly. And you may want to go check some of your votes on that. So I don't think that's a good argument at all. And I may, you know, yes, there's going to be injuries to anything in medicine or whatever profession. There's going to be situations. My sister, for almost 2 months when she was a child, a vaccine more or less paralyzed her. She slowly regained use of her legs, and she's normal today. You know what? Her child had all the vaccines that were required or asked upon by the school system. Same vaccine that hurt her child took. You know what? Didn't hurt him, but you know what? He's protected from smallpox. Thanks.
Chairman Williams, you're recognized.
Thank you. I can appreciate the fact that my good friend from Davidson County brings his children in here, but there were and talks about them. I think it gets a little personal when we do that. I do know that in my family I have people who did not choose to take the vaccine, who had friends who fell over and had to be resuscitated with an AED, and their parents encouraged them to do so. I think the thing that we can agree here in is, as parents, it's your decision to make as it relates to your child. Your children, as minors, didn't make that decision on their own. So I appreciate that very much.
Chairman Reagan, any closing comments?
The only closing comment I'll make is just to echo what I said earlier. Children belong to their families, not to anyone else. We hold parents legally responsible for taking care of their children, as we should. With that responsibility should come the authority to make the decisions that affect those children. Committee members, I ask for a positive vote. Thank you.
You ready to vote? All those in favor of sending House Bill 1380 to full Health Committee, please signify by saying aye. Aye. Any opposed, please say no. No. If you'd like to be recorded as a no, please let the clerk know the bill passes with a predominance of aye votes. House Bill 1380 will go to full Health Committee. Chairman Reagan, I apologize. We have run out of time. And,
I understand, sir.
As was announced on the House floor last night by Chairman Terry, we still have a few bills left on our calendar that we want to try to finish this week. And we are going to convene our House Health Committee, the full committee, at 3 p.m. tomorrow. Upon adjournment of 3:30, pardon me. House Health Committee will meet at 3:30 tomorrow. Upon adjournment of full House Health Committee, we will reconvene House Health Subcommittee and work to finish off the rest of our calendar. So once again, at the conclusion tomorrow of Health Full Committee, we will reconvene this subcommittee to finish off our calendar, hopefully. With all that said, this committee is adjourned. Did I do okay?